Okay, thank you. That's a lot easier, although I'd love to have given your talk, Barbara, as well. Okay, so why are consumer attitudes important? The first thing is that it's what consumers think about, who they trust, their attitudes, their psychology about their ability to control their own health, which will make an enormous difference as to whether they'll adopt personalised nutrition. And realisation of public health benefits is going to be dependent on understanding who will adopt personalised nutrition, but also what kind of barriers exist to prevent people adopting personalised nutrition. So what barriers to adoption can we identify? Are some of these psychological and are some of these pragmatic? I'm just going to report on the three main phases of the research. There was also a fourth phase, deliberative workshop, which I believe has been covered elsewhere. So the first phase, the qualitative research, consisted of a series of focus groups run in 8 different European countries. And there we were particularly interested in understanding consumer perceptions of benefit, risk, and also cost associated with personalised nutrition. And cost can be financial, or cost can be in terms of time or difficulty, or somebody giving something up to enable them to adopt personalised nutrition. We followed this up by a big quantitative research with 9,000 consumers, where we started breaking down individual differences between countries, between types of consumer. And in the third phase, we compared this general population sample with participants' opinions at the end of the proof of principle study that John's already described for us. Now, I have to be honest, this is still work in progress, but I'm going to report some of the initial results from that research. And this just lines it out, outlines it so that you can see more easily how we proceeded. The qualitative research, developing the questionnaire using the outputs of those focus groups, a pilot survey, the big pan-European survey, and then the comparison between the general population and those involved in the POP study, of whom 729 provided usable final questionnaires. So that's a jolly good sample. The focus groups were conducted in all of these countries. And the results really suggested that the extent to which individuals perceive personalised nutrition to benefit them was the main driver of whether they would adopt it. Risk was raised, but it wasn't the risk of personalised nutrition. It was much more linked to the ICT delivery systems, data protection, some of the generic issues associated not only with personalised nutrition, but individualised medicine in general, that acted as a barrier to people potentially adopting personalised nutrition. So there are concerns about internet delivery, data protection, trust in regulators and service providers. Interestingly, for those with a kind of business head, services that required a fee were expected to be of better quality and more secure, but we'll come back to how big that fee should be later on. And developing trust in service providers was important, but the focus groups also showed that perhaps trust in some service providers was very low, that there needed to be involvement of health professionals, people with an interest in people's healthcare. So overwhelmingly, there was this issue of a preference for delivery via a health service provider and the involvement of health professionals in the delivery of personalised nutrition. The survey was developed using the results of the qualitative research and also the theoretical literature. We used gold standard methodologies, WHO gold standard translation and back translation into the languages in which the survey was run, which was all of these countries. It was administered over the internet. And we had a response rate of 23 to 39%, depending on the country involved. So that's actually not bad. A total of 9,381 participants were included in the study. So a very big sample. And those are the questions that we asked. We developed a suite of items, as well as collecting information about people's demographics, their health status and dietary restrictions. These psychological factors were all included using quite extensive and well-validated scales. And then we have a list of other psychological factors that we looked at. Health locus of control, the extent to which people perceive that they personally can control their own health through their behaviour. Eating habits, do people tend to eat the same things all the time, habitually? Do people feel able to change their diet? Food self-efficacy, motives for food choice, their attitudes towards personalised nutrition, their intention to adopt it, and their willingness to pay for it. So, a huge amount of data. This was the model that we developed using this data set. And there's two things I want to pull out of it. The first, that the most important factor that predicted people's intention to adopt personalised nutrition was the extent to which they perceived there was a benefit associated with it to them. Risk, although there was an inverse relationship with benefit perception, did not predict people's intention to adopt personalised nutrition directly. So benefit is very important. The other factor, which is very, very important, is the extent to which people think they can adopt personalised nutrition. Is it easy? Is it convenient? Do people's lifestyles mean that there are other barriers to adopting personalised nutrition? That kind of confirmed a lot of what we found in the focus groups and the kind of information that you might find in the literature. So to summarise, benefit perception is the most important determinant of people's attitudes towards personalised nutrition and their intention to adopt it. Perceived self-efficacy, the answer to the question that people will ask themselves, is personalised nutrition achievable, will predict both attitude and people's intention to adopt. One interpretation then is that when we develop communication about personalised nutrition, we need to communicate about personal benefit and ease of adoption. Looking at the kind of barriers which emerged in the focus groups, again, these seem to mainly relate to issues of trust. The barriers are not particularly focused on personalised nutrition, but data misuse by insurers, by advertisers. There's this issue of data storage, particularly in relation to genetic data. The data may be accessed by hackers. It may not be treated in a confidential way. The only issue here that personalised diet may not be effective, that really emerged as important, is something that can, again, I think, be addressed through communication. Willingness to pay, though, for personalised nutrition. If we look at the general population, we found that about 30% of the population is willing to pay more for personalised nutrition service than for a generic nutrition service. We found that across the entire population sample. So we adjusted the costs according to how much dietary advice would cost in a particular European country. So this is not an absolute sum. It's been weighted according to which country the participants lived in. Of that 30%, if people are willing to pay more, they're willing to pay around 50% more than for generic services. Although that doesn't sound like a huge figure, 30%, if you think of the population of Europe, it is. So perhaps if you're developing business models, you might like to start looking at that particular segment. Unsurprisingly, people in the highest income groups are willing to pay the most. I suppose this also raises some questions about access to to personalised nutrition. Should personalised nutrition be excluded from insurance or human resource management programmes, or should it be included? That would be a way of giving at least some people access, but perhaps not the most excluded people in society. Or perhaps the alternative view, that personalised nutrition in some way needs to be embedded in health service provision, which raises the issue of how public-private partnerships might evolve to deliver this through the health services. So the third issue is the work package 2 for comparison. So we compared people in our general population sample with those who completed the questionnaire at the end of their 6-month involvement in the trial. What we were expecting was that the perceptions and attitudes of those involved in the trial would actually be more positive than for the general population, partly because they had a good experience with the trial. They obviously completed it, so personal experience is potentially a way of improving people's attitudes. But we're also looking at differences between the different conditions in the trial. So was intensity of feedback a positive or a negative issue? We were expecting more intense feedback to result in a more positive experience and more positive attitudes. And just to recap, of course, we had the 4 conditions: the control, the individualised dietary advice based on diet alone, dietary intake plus phenotypic data, and then the addition of the genotypic data. So, were these 2 populations different? I realised that there were 9,000 folks in the big general population sample and around 730 in the smaller sample. But what we did was use a statistical technique called propensity matching to match along demographic and some attitudinal variables the people in the general population with those in the trial. So we've got a pretty good idea that on those key variables, these 2 populations were very similar. We indeed found that those people who had been involved in the trial had more positive attitudes than those who hadn't. And there is a big body of literature which suggests that personal experience with a service or a product makes people more positive towards that product if, it's delivered for them, which I suspect it did in this case. We saw the evidence from John's presentation. There is a caveat. We don't have the final attitudinal data for people who didn't complete the trial. And that would have been useful because that could have allowed us to perhaps produce recommendations or tweak delivery in some way to align with the needs of those individuals. But, well, we can't have everything. we did have some unexpected findings. We found, for example, that participants in the trial had the most positive attitudes following the low-intensity feedback condition. That in the high-intensity feedback, some of them had higher scores on things like boredom, or they also seemed to feel that the high-intensity feedback reduced their ability to personally control their health. We actually want them to have a high score on that. So one conclusion here is perhaps that we need to make sure that the level of intensity of feedback aligns with consumer preferences, and perhaps let them select whether they want high or low intensity feedback. But this is fine-tuning. This isn't a major barrier to adoption. It's a preference for how it's operationalised. The other surprise was, and actually I think this again aligns with the results of Work Package 4, is that there were no differences in attitude associated with the level of medicalisation. So dietary intake, or whether they were getting phenotypical or genetic advice being returned to them. It seems that getting personalised nutrition advice is the thing that really counts here. So some conclusions. People will primarily be interested in receiving information about potential and personal benefits of adopting personal nutrition. So that's a generic conclusion, but what I think needs to be underlined here is that what those perceived benefits are may vary between individuals. Some people might be in this for weight loss, others about disease prevention, and we do need to understand what is a benefit to different individuals. We also need to give them information about the ease of adoption of personalised nutrition. So not only that their involvement in individualised dietary advice is going to be beneficial to them in ways that they appreciate, but they can also do this, they can attain this. The whole issue of trust really speaks to the need to develop transparent regulations regarding protection of data, in particular, but not exclusively, genetic data. People want information about how this is enforced across the public and private sectors, and this also needs to be communicated to the public. So how do regulations protect the public in terms of their data not being nicked and misused or mishandled? What's being done to optimise consumer protection? And of course, this isn't just to do with personalised nutrition, it's to do with individualised medicine, a whole lot of other issues where data protection is a concern. I would also say that we need to develop trust through engagement with the public regarding the design of the legislative infrastructure and subsequent implementation of regulations. So, understanding what the public want from data protection. Personalised nutrition providers must be perceived to be credible. There has to be expertise underpinning the service that's being offered, in particular evidence of a health professional being involved with the service. Increasing the intensity of feedback may be counterproductive for some consumers. Allow people to select the level of feedback they want. And I think this is going to be followed up in our debate. If only the most affluent participants in our studies are willing to pay for a personalised nutrition service, we need firstly a careful analysis of the costs required to provide such a service. We also need to think about the equity of distribution of benefit from personalised nutrition across all of our population, including those who are the most vulnerable. My last slide setting the stage for our debate. Is there a tension between public health policy, personalised nutrition for all, and innovation policy, the growth of the industry sector? Can we reach a compromise through the development of public-private partnerships? I have a question about the general population sample. Many consumers did not adopt healthy diets, independent of whether they're personalised or not, and that's a question mark. Perhaps personalisation will encourage more people to eat healthily and have a real impact on public health. But how do we follow through with that potential finding? And finally, as individualised medicine becomes more mainstream, I suspect attitudes to personalised nutrition are likely to become more positive, because people will be more familiar with the underpinning concept. It's not going to be in food choice alone, it'll be in other areas of medicine. And perhaps that willingness to pay result may change. Perhaps people will become more positive about paying for personalised nutrition services. But again, I think we're going to hear about that in our debate. So finally, I'd like to say thank you to everybody. This has, again, been a great project. These are the universities involved in Work Package 2. And I guess also like to thank Maren in particular for keeping us all on track and just being fantastic. So thanks, Maren.